Hi, everybody. Thank you for being here today. I love talking about melatonin. It's such an exciting hormone. It has such incredible actions in the human body and many, many applications for clinical practice. I'm just going to move my little floating head here. So these are the learning objectives that we're going to be going over today. We're going to be talking about how and when the body secretes melatonin, what the relationship is between melatonin and cortisol, how melatonin is associated with so much more than just the sleep and wake cycle. We're going to look at the impact that age and lifestyle choices have on the production of melatonin. We'll be looking at safety of supplementing throughout the lifetime, including pregnancy and childhood. We're going to be looking at how melatonin naturally occurs in food, and we'll just be discussing lots of different supplementation considerations. Mostly what I'm hoping is that by the end of this presentation, it will be very clear to you what a valuable tool melatonin is for you in your clinical practice. So this is what most of us think of when we think of melatonin. It's that circadian signaling that we associate with light and dark in a 24-hour period. So you can see in this image here how light inhibits melatonin production and secretion. And at night, in darkness, melatonin reaches its maximum level in the middle of the 24-hour photo period. So that's usually between 12 and 3 a.m. These messages of inhibition or suppression travel via the suprachiasmatic nucleus, or the SCN, to the superior cervical ganglia, and then back up to the pineal gland via sympathetic nerve fibers. But this image just barely scratches the surface of the impact that melatonin has on the body writ large. Here you see the bigger picture, a representation of melatonin's effect on the entirety of the human body. It's recently been discovered that in addition to the pineal gland, melatonin is also produced in the heart, liver, uterus and genitals, placenta, kidney and adrenal glands, immune cells, and thymus, serving a locally protective and modulatory role. As well, melatonin receptors have been found in the suprachiasmatic nucleus and the cortex, the retina, the spleen, the liver, the genital and mammary glands, the uterus, the thymus, the GI tract, also thrombocytes and lymphocytes. So all of this to confirm melatonin's unique hormonal role due to the diversity of locations where it's synthesized and secreted and where its receptors are located. My goal for this presentation is to bring you beyond that previous image of melatonin's function in sleep to see how it impacts on circadian rhythm, affects every single aspect of human physiology, metabolism, immune response, reproductive function, and other vital physiological processes, which we are going to be discussing at length. So chronos means time, and melatonin is a chronobiotic, which is a biological agent that can phase shift the circadian rhythm. And I'm going to explain what that means in just a second. Melatonin is produced from the serotonin pathway. This depiction is from the Doctor's Data neurotransmitter pathway chart. You can see that once serotonin is formed from tryptophan and 5-HTP in the absence of light, the enzyme N-acetyltransferase, or NAAT, attaches an acetyl group to the indole portion of serotonin. Then the HIOMT enzyme catalyzes the final reaction by converting acetyl serotonin into melatonin. Note the nutrient cofactors in red that are essential for these biochemical conversions. P5P, the activated form of B6, iron, BH4, which is endogenously produced, supported by SAMe, B3, vitamin C, molybdenum, and zinc, vitamin D, and finally SAMe again for that very last conversion into melatonin. Here you see how the suprachiasmatic nucleus of the hypothalamus detects and entrains the physiological rhythms of the human body to this 24-hour light-dark cycle. In the middle of the night, that release of melatonin induces the shift from day to nighttime functions. And that's really important to understand, that there are daytime functions in physiology, and then there are nighttime functions, such as a decrease in blood pressure while we're sleeping, slowing down our metabolism and reducing our body temperature. Of course, the opposite happens during the day, when light suppresses melatonin and physiological rhythms shift to daytime functioning. So I love this picture because of just this little concept of a clock on every organ and every cell of the body that, ultimately is going to be responsive to melatonin. Not every cell, but most cells of the body. And here's a simplified image of that 24-hour circadian cycle, where you can see when certain physiologic functions naturally happen at specific times due to that interplay of melatonin and cortisol. So note that peak melatonin, so the blue on the right here is nighttime, on the left, the light obviously is daytime. So note that peak melatonin levels occur in the middle of the night when temperature is at its very lowest during deep sleep, preceding peak lymphocyte levels. Body temperature and blood pressure peak in the evening before that melatonin starts to increase. So that if one is doing things at the wrong time of the cycle, such as eating too late in the evening, it can interfere with this delicate timing of all of these processes. And keep in mind too, that this can have a dramatic impact on general health, such as we see in shift workers who have an increase in tumor incidence and a 23% higher incidence of obesity or being overweight than controls. Note that all of this varies a little depending on each person's body clock. But with a balanced circadian rhythm, these functions happen naturally and on this schedule. If you want to learn a little bit more about how everybody's body clock is slightly different, there's a great book called The Power of When that goes through that. And here's a linear representation of the melatonin curve. You can see the gradual rise around sunset. We call that the dim light melatonin onset, the DLMO. This is when temperature starts to decrease, and a significant rise in melatonin around 9 p.m., the peak in the middle of the night. And then you can also see just how melatonin levels are really low during the day. And the representation here is in the daytime, cortisol in black is at its highest, melatonin is at its lowest, and then as cortisol decreases throughout the day, toward the very end of the day, melatonin begins its ascent. It is at its highest in the middle of the night, while cortisol is at its lowest. And one more depiction here, in red, this is temperature. This is the sleep period, this gray section here. So plasma melatonin at its highest, cortisol at its lowest in black, and temperature at its lowest in the middle of the night. Disruptions in the melatonin curves are called phase shifts, and this may present clinically as disordered sleep patterns. So here you see a healthy melatonin rhythm in blue in the middle, while the dotted green lines represent phase shifts, a phase advance to the left, such as you would see in early birds and the elderly, and a phase delay to the right, as you would see in adolescents and night owls. Melatonin has been shown effective in sleep onset latency, meaning it can shorten the amount of time that it takes to transition from fullness into sleep. I think it's important to understand the unit of measurement of light, which is called lux. The higher the lux, the brighter the light, and the more suppression there's going to be on melatonin during the day. So this chart shows you that a sunny full spectrum day is 100,000 lux. A cloudy day is 1,500 lux. That's a big difference. Rainy days about 1,000, sunrise and sunset around 400. Indoor lighting is 300 to 500, similar to sunrise and sunset. So that's a pretty dim light. And light boxes are about 10,000, right? So much closer to a natural full spectrum light, but still not going to be the same as getting outside and getting all that light. So I bring this up because a lot of people spend their entire day inside, and there's just not going to be enough suppression of the melatonin with indoor lighting. It's better than being in darkness throughout the day, but it's not going to come close to that suppression that's needed for that circadian rhythm as you would get from a light box, or, better yet, from spending some time outside each day. And here's an example of what those full spectrum lights look like. They're also called happy lights, and they're about, you can get them from starting around $30 online. There's even some alarm clocks that you can get that help you to wake up to light. So blue light from technology is the most suppressive light to melatonin, as it's been shown to decrease production by 91%. But the good news is that this imbalance can be counterbalanced by exposure during the day to either full spectrum light indoors or to outdoor light. So just getting outside can help to attenuate that decrease of melatonin. Everyone's really curious about melatonin supplementation, and these are the most common questions I get. Should I give my patient melatonin? And hopefully this presentation is going to help you to answer that question for your patients. Is it safe to take melatonin? What dosage should I be using? And will it suppress native production? I'm going to go through all those questions. There is just a lot of misinformation on the internet about melatonin's suppressive effect on the endogenous production, and the research just does not support this. I'm going to give you a couple examples of research that has addressed these concerns. So in this particular research, test subjects served as their own controls. Morning melatonin was the same, whether they supplemented with 500 micrograms the night before or not. And these results were replicated with 2 and 5 milligram doses. Here are a couple more studies showing on the left, the amplitude of endogenous melatonin was not affected by melatonin treatment in shift workers who served as their own controls. And on the right, during a 6 to 12 month open label RCT of community dwelling adults aged 20 to 80, found that discontinuation was not associated with adverse events, rebound insomnia, or withdrawal, and there was no suppression of endogenous melatonin production. So to address the question, what is the best dosage of melatonin? Here is a summary of 187 references of melatonin dosing in the research for different purposes. So a couple examples, when melatonin is used in cancer, this particular survey said that dosages can go up to 20 milligrams. I've seen up to 50. Analgesia for pain, 3 to 5 milligrams at bedtime. Pre-medication for anesthesia in pediatrics, 0.5 milligram up to 20 milligrams. Insomnia, pretty typical research studies are 3 to 5 milligrams. Jet lag, 0.5 milligram to 2 milligrams. So you can just see that, the dosing is really wide and really varied because melatonin has an incredibly high safety profile. Patients often ask when they will feel the effects of melatonin in regards to sleep improvement. This research study explored just that in postmenopausal women and found that 64% of the women improved their quality of sleep at the very beginning of the administration of melatonin, whereas 35% didn't have any significant improvement in the first month. But this group was comprised of women who had previously taken hypnotic drugs for sleep. They found that in this group, 6 to 8 weeks of supplementation did improve their sleep quality and length of sleep, but it took a couple months. So just keep that in mind, that not everybody's going to have an immediate response to melatonin. And not all melatonin is created equal. Dosing melatonin is very strategic, and it depends on whether one has trouble falling or staying asleep. Immediate release acts on the timing of falling asleep or that phase advancing of the melatonin rhythm. Melatonin has a short half-life in the body. It's only about 30 to 60 minutes. And a physiological production of melatonin is a very low amount in a day. It's about 0.3 to 0.5 milligrams per 24-hour period that our pineal gland is naturally producing. So starting as low as possible and working up from there would be the best course of action. Sustained release you give at bedtime to prevent that sleep offset insomnia or that agitated, disturbed sleep. The sustained release, so the immediate release has about a 30 to 60 minute half-life. The sustained release has about a 3.5 to 4 hour half-life. So it's going to be a gradual release over time. It could even release over up to 8 hours. And usually the sustained release formulas are somewhere in the 1 to 5 milligram range. And as I mentioned, you would give this to your patient right when they go to sleep. But as mentioned, not all melatonin is created equal. There have been some research studies that have shown that what is marked on the label as a dosage does not necessarily match what is the actual dosage in that product. A couple different research studies have shown that. This was a study in Canada, over-the-counter supplements from grocery stores, and they found that the melatonin content did not meet the label claims, even within a 10% margin in most of the supplements that were tested. And there was a range from minus 83% to 478%, huge range of how different the claim on the bottle was versus what was actually in the product. So this is why it's important that your patients are using what's called a physician grade or a professional grade melatonin, so that they can ensure that they're actually getting what's on the label. And this is one of the reasons that people have had such bad experiences with melatonin. I very often hear melatonin didn't work. I ask them where they got it. It's usually at, some grocery store, and who knows how much they were getting. And usually that's immediate release versus sustained release. And that is going not necessarily what everybody needs, because some people need that help with the middle of the night waking. So when to take melatonin gets a little dicey, as there is a lot of diversity around this topic in the literature. Usually the research is done on fast-acting melatonin in capsule or tablet form. Some studies have concluded that dosing 6 hours before the midpoint of sleep is ideal. So the way that would look is that a person who wants to sleep 8 hours from 11 to 7, the ideal dosing time would be around 9 p.m., approximately 2 hours before they want to go to bed or they want to be asleep. But other research shows that 60 to 90 minutes before bedtime is the desired amount. And you're going to see some research in just a minute that shows that 2 to 7 hours before the dim light melatonin onset is the best way to phase shift forward for somebody who has a delayed bedtime or can't get to sleep with insomnia for a long time. So this is that graph that I was just talking about. It's based on literature reviews of RCTs, and I think it's a great little tool to help you figure out dosing for phase advancing and delaying dosing of melatonin. So on the left in blue, this phase here, starting around 3 p.m., is the phase advance zone, meaning that if you dose melatonin in this range, you will advance sleep. So this is for night owls and for teenagers who fall asleep too late. This pink dead zone denotes a range where if you take melatonin, it's not going to phase shift. Now, interestingly, this is a new concept to me. And that is the phase delay zone, this green zone here that starts around 3 a.m. and goes until around 9 a.m. So that means that if you dose melatonin in this zone, so giving somebody melatonin in the morning, you will phase delay their falling asleep later that night. So this is for early birds that just, fall asleep right after dinner and get up too early in the morning, and it's hard for them to live a normal schedule. So you could actually give them a little bit of melatonin in the morning before that dim light melatonin goes off, an hour before, within an hour before, or within an hour after, to try to get them to stay up a little bit later at night. And this shows you a similar approach with these phases using light pulses to phase advance and delay the melatonin rhythm. So the green zone, okay, so this is the control, right? Melatonin, this is just a normal, happy melatonin, rise, DLMO around 9 o'clock, peak in the middle of the night. This is what we're going after. The green zone represents the timing when light pulses are going to provoke the maximum phase delays of the circadian clock. So look how this looks. So here are some light pulses. This one is at 9 o'clock. This is a little bit before midnight. And this dark line here is the melatonin curve. Look what happens to melatonin when you're dosing light. Now, this can be a way to phase shift later for someone who's falling asleep too early to get them back into a better rhythm. You wouldn't be doing this with them every single night. But what I find the most profound about this chart is how many of us are going without light between 9 p.m. and when we go to sleep at night. So look what happens to our melatonin curve. That means that most of us who are not going without light are going to have an attenuated melatonin curve. So again, to answer that question, does my patient need melatonin? Does your patient have a curve that looks like this? Are they dimming their lights at around 9 p.m. at night, or even earlier when that dim light melatonin onset starts, so that they're going to be having the ideal environment for that melatonin to start to rise? And if that's not the case, then perhaps they would be a good candidate for some melatonin supplementation. And then, of course, if you use if you use light in the morning, so this is again light pulses. If you use a light pulse in the morning, that's going to help those night owls perhaps to get up a little earlier, and so that they're not staying up so late at night. So we mentioned again the range of dosing for fast-acting melatonin. It's usually a little bit lower for the sustained release. So anywhere between 0.5 and 5 milligrams. I like to start as low as possible with the immediate release. Give it to my patients anywhere from 30 minutes to 2 hours before they go to bed, depending on the person and what they need. And again, that's sustained release. Usually you can't find something less than 1 milligram. It's going to be acting for a longer amount of time. And you give that right at bedtime. And just a little cheat sheet here for how to use full spectrum light. 20 to 40 minutes in the morning is going to phase advance for those night owls, and 20 to 40 minutes after 5 p.m. is going to phase delay for those morning larks. So another question that providers get frequently is, are there any side effects from melatonin supplementation? Generally speaking, melatonin is known to be very well tolerated with an excellent safety profile and very, very few side effects in the literature. However, there are some reports the day after using melatonin to fall asleep of fogginess, grogginess, maybe feeling sleepy, dizziness. Sometimes people experience increased urination at night when they take melatonin. There might be some nausea, mild diarrhea, mild headache. Honestly, I've seen so little of this in my own practice, very, very little. When I hear people say they've experienced this with melatonin in the past, again, I ask them the question where they got it, what was the dosage? They usually don't know that. So we start over with better dosing for them. These are two recent review papers. The first one is from 2019, 37 RCTs with doses ranging from 0.15 milligrams to 12 milligrams, duration of 4 weeks to 6 months. Adverse effects were mild, and they resolved spontaneously within a few days of withdrawal of treatment. The second one is a narrative review of RCTs from 2016, 1 to 100 milligram dosing range in duration of days to months. This research also found mild adverse effects. The authors made an interesting point, suggesting that because of melatonin's hypnotic, analgesic, and anti-inflammatory qualities, it should be compared to the safety profile of benzodiazepines, opioids, NSAIDs, and glucocorticoids. All medications that have some similar qualities in terms of sleep, but have short and long-term adverse effects and can cause major complications and morbidity. Whereas melatonin at high doses really doesn't have any serious side effects. So here's some more drug interactions. Drugs that are metabolized by CYP1A2 liver enzymes, such as fluvoxamine, antidepressant, caffeine, and oral contraceptives can increase plasma levels of melatonin. This isn't necessarily dangerous, but just something to keep in mind. If you are giving somebody melatonin while they're using these medications, the effects could be greater for them. Sorolin and cimetidine may also increase plasma melatonin levels. Carbamazepine and rifampicin. Cigarette smoking has been shown to, carbamazepine, rifampicin decrease melatonin levels. Cigarette smoking has been shown to increase it. And be careful of melatonin in combination with hypnotics such as benzodiazepines, because it can impair their psychomotor performance and memory. Because melatonin is contained naturally in some foods in the form of melatonin in animal foods and phytomelatonin in plants, the U.S. Dietary Supplemental Health and Education Act of 1994 allows it to be sold as a dietary supplement, for which regulations are less strict than for over-the-counter drugs. This is from the American Academy of Sleep Medicine's best clinical practice guidelines from 2015. I wanted to include it because it confirms the value of functional medicine practice that we're talking about in this presentation. So the best practices suggest that in adults with advanced sleep disorder, which is ASWPD here, those folks who fall asleep too early, they should be treated with evening light therapy. So this research found that the most effective thing is to use light in the evening. They found that in folks with delayed sleep disorder, that melatonin timing is what is most effective in phase advancing. So serum melatonin concentrations vary considerably according to age. Infants younger than 3 months secrete very little melatonin. Melatonin secretion increases and becomes circadian in older infants, and the peak nocturnal concentrations are highest at the age of 1 to 3 years, after which they gradually decline. And note that puberty occurs just as melatonin starts to begin this decline. As shown in the last slide, melatonin production and rhythms don't start to develop in infants until around age 3 months. No surprise there for anyone who has cared for a newborn and has suffered the sleepless nights of their unpredictable rhythms. Experts believe that this is why some babies experience colic during this time, as melatonin has been shown to relax and smooth intestinal muscles. Breast milk introduces melatonin, which helps the infant to establish natural sleep. As with adults, short-term studies in children have been shown to be safe with only transient and mild symptoms. Bear in mind that studies in children are done in specific populations, such as children with autism and ADHD, who also have insomnia, because it would be unethical to do a huge trial on children in the general public to see how they tolerated melatonin, or to look specifically at how melatonin might impact puberty. So all of these findings are incidental from other research. Note the hardy doses that are used in the literature for children. The dosing here ranges from 2 to 10 milligrams for children ranging in age from 2 to 17, and they dosed it for 1 to 3.5 years. No safety concerns were noted. It's been well tolerated and considered safe and efficacious in study after study. Only 3 human studies have tracked the impact of melatonin supplementation on pubertal timing. And as mentioned, it was a secondary outcome. One study found that, it was a study that looked at 59 6 to 12-year-olds. They used melatonin for 6 months or more. 19 of them reached puberty during the study, and there was no difference in timing compared with the population norm. They took that same group of kids 10 years later, and they looked at them again, and found that 31% of them reported a perceived delay in sexual maturation. So that was their own opinion. But another group of researchers looked at the Tanner stages for these kids from the original trial and determined that long-term melatonin use did not have any effect on their timing. Another longitudinal study of 44 children with neurodevelopmental disorders who took 5, 10, and 15 milligram doses for about 4 years showed normal timing of puberty. So we definitely need more. We need more research in this area. The way that I address this in my practice is that I give very, very tiny doses. If somebody is nearing puberty, I may withdraw the melatonin and give them some of my other tried and true things for sleep, P5P, L-theanine, nervines, etc., instead of melatonin. And then once they've gone through puberty, I'll give them the melatonin again, very low doses. This is the review article that the previous slide was based on. Lots and lots of references, so you can take a look at that if that interests you. So anyone who works with patients who are perimenopausal and menopausal know that this stage of life can have a significant impact on sleep. I was surprised to learn that there is a higher percentage of perimenopausal women here on the left, 56% of them sleeping less than 7 hours per night compared to menopausal women, where only 40.5% slept than 7 hours per night. So the bottom line here is that our perimenopausal women and our menopausal women are really being impacted by these hormonal shifts, and melatonin can help them greatly. As mentioned, there is a clear link between decreased sleep and aging. As we age, we wake up more frequently, we fall asleep earlier, and we sleep fewer hours. So this phenomenon seems to be due to a reduced circadian signal, which results in an earlier wake time and a 1 hour advance of core body temperature and melatonin. So that phase advance. Sadly, for as common as it is, insomnia in the elderly tends to be undertreated, and it's an area where functional medicine providers really have a lot to offer. Strangely, the pineal gland is the organ with the highest calcification rate. Why is that? Well, it seems to be very sensitive to chronic vascular inflammation, which can increase mesenchymal stem cells, MSCs, which, along with melatonin, form bone. The inflammation arises from brain tissue hypoxia from a variety of reasons: hypertension, sleep apnea, stroke, even respiratory disorders can promote these MSCs. Also, intracranial pressure from an injury, such as brain trauma or stroke or Alzheimer's, is also going to increase those MSCs. And note that the recurring theme here with this calcification is inflammation. So here you see pineal calcification, upper left A. This is in a 14-year-old. It's just starting. B is a 47-year-old. C is a 62-year-old. And D is comparing the pineal calcification to actual bone osteons. And you can see the similarity there. So some environmental hazards are theorized as causing this as well, such as fluoridated water, that this could contribute to pineal calcification. Also, maybe Alzheimer's, MS, migraine, they all tend to be associated with an increase in this MSC formation, causing some of this calcification. It's theorized also, again, this is a topic we don't know a lot about, that melatonin supplementation can neutralize the reactive oxygen species and decrease the inflammatory and injurious processes that are taking place here. So it's ironic that these pineal glands are not working properly. They're not producing enough melatonin. Melatonin is highly anti-inflammatory and antioxidant. And ultimately, what these pineal sites need are melatonin, which crosses the blood-brain barrier. So here are some other factors that may contribute to melatonin decrease over time. We've been talking about this: blue light, inadequate darkness for the DLMO, just some things for you to look at on your own. Also the medications that we were just talking about that can interfere. So some additional factors that can decrease melatonin is alcohol within 4 to 6 hours of bedtime. Seasons, right? Shorter periods of production in the summer and longer periods of melatonin production in the winter. Something to think about with your patients in terms of dosing and whether or not they need melatonin, because it's natural to be producing less of it in the summer and natural to produce more in the winter. Stress, adrenaline, cortisol, all going to suppress melatonin. Definitely things that we don't want at night when we're getting ready for bed. You know, the importance of sleep hygiene being highlighted here. Caffeine, even in the morning, for some people is going to severely impact their melatonin production. And then, of course, those cofactor deficiencies for that cascade that we already discussed. So we touched a little bit on newborn babies. So let's talk a little bit about melatonin in pregnancy. So maternal plasma levels are elevated during pregnancy, and they reach a maximum at term, and then they return to baseline levels soon after delivery. Melatonin readily crosses the placenta and the blood-brain barrier, so benefit for the mother and for the baby. Melatonin receptors are widespread in the human fetus from early fetal development on, and the high plasma levels in late pregnancy are thought to contribute to fetal neuroprotection and perhaps to circadian rhythmicity. There's quite a bit of research on melatonin supplementation and fertility. Melatonin supplementation has been shown to improve egg quality and increase pregnancy rates with in vitro fertilization by 50% versus cycles that didn't include melatonin. And in women who had previous IVF failures, a cocktail of 3 milligrams melatonin plus 4 milligrams of myo-inositol for 3 months improved oocyte quality and fertilization rates. Note that no maternal, embryo, or fetal toxic effects have been reported, and that in rat studies, they have found no lethal dose, even with extremely high doses of 800 milligrams per kilogram. Even in newborns, there's general agreement that melatonin has a remarkably benign safety profile, even at pharmacological doses with very few side effects. It's been extensively used in conditions related to prematurity, such as RDS, BPD, and neonatal sepsis. And as mentioned, in addition to its use in ADHD and autism spectrum disorder, it also shows promise in children with seizure disorders. And again, for ethical reasons, studies haven't been run on pregnancies that don't involve fertility intervention. Breast milk contains melatonin, and it reflects the diurnal rhythm with low levels during the day and high levels at night. Breastfed babies have been shown to have longer sleep times than formula-fed babies, which is likely attributable to the lack of melatonin in formula. And it's suggested that mothers nurse in the dark at night to prevent, so at night, that mothers should have the lights off as much as possible to ensure that appropriate amounts of melatonin are being captured in that breast milk. And it isn't until the end of those first 3 months that newborns start to produce their own melatonin. I found a really interesting study on frozen human breast milk, and they found that there was no difference in melatonin levels in fresh or frozen. But they did make an important point that mothers should always differentiate which milk was pumped at night and which was pumped during the day, and supplement their baby accordingly to ensure that they're getting the highest levels of melatonin at night. Melatonin was first isolated from bovine pineal gland in 1958. And it was first identified in plants in 1995. That was only 25 years ago. So it's an area of emerging research. Melatonin refers to the compound from animal origin, and phytomelatonin refers to that of plant origin. Research has shown that an increase in serum melatonin levels after consuming foods rich in phytomelatonin, but that this does not have a sleep-inducing effect because levels are really quite low during the day. As with the human body, melatonin has many protective and beneficial effects in plants, from protection against oxidative stress to regulation of the circadian rhythm to promotion of seed germination. I find this really fascinating. This article pointed to the presence of melatonin in the Mediterranean diet as being one of the reasons that the Mediterranean diet has such beneficial effects, pointing to the high levels of melatonin in olive oil, tomatoes, grapes, and wine. Here's some more research on phytomelatonin's effect on antioxidant capacity, or ORAC levels, and sleep quality. And even some promising animal research pointing to its hepatoprotective and cardiovascular effects, phytomelatonin. So what better way to receive a steady inflow of low levels of antioxidant-rich, anti-inflammatory melatonin than through the diet? Note that the highest levels are found in walnuts, meat, fish, and eggs. Having said that, phytomelatonin in food will not contribute to sleepiness, as mentioned, but you do get that the benefit on the circadian rhythm. This slide lists commonly utilized herbs and plants that are high in melatonin. Note that herbs like chamomile and skullcap and even curcumin are high in melatonin, and these are all things that have been found to be beneficial to sleep. All the fruits on the right, tart cherry is very high in melatonin, and a lot of people will take this at bedtime instead of a more synthetically derived melatonin. Grains and nuts on the left, note that rice has one of the highest levels of melatonin in food. And on the right, miscellaneous foods and beverages such as beer, wine, and green tea also been shown to have high phytomelatonin profile. So how does this apply to your clinical practice? So this, if you're going to be testing melatonin, this is what an optimal curve is going to look like. So this is the melatonin decreasing in the morning when the person wakes up. In the evening, it begins its rise, and at nighttime, it's at its highest in this curve. This is an example of a patient who had low melatonin levels in the evening, which corresponded with her difficulty falling and staying asleep, and was most likely related to the fact that she was looking at that blue light right before going to bed. This curve shows interference from 5-HTP that was used the night before. So if you see something like this, where it's very high in the morning, query what your patient took the night before. Did they take melatonin? Did they take 5-HTP? Again, 5-HTP on that serotonin pathway, which could lead to increased melatonin levels. So we recommend that somebody avoid foods that are rich in phytomelatonin and 5-HTP and melatonin for a good 24 hours before they do their testing. This is a 14-year-old male. It's a very typical pattern of melatonin elevation in the morning because they're still sleeping. To give you an idea of what that phase delay looks like. This doctor did not also order cortisol levels, but we can assume that they were going to be quite low in the morning just based on how high melatonin levels were because of their counterbalancing each other. It's not surprising that this patient reports severe morning fatigue and difficulty falling asleep at night. A good treatment strategy for this patient would be a light box in the morning, and then melatonin supplementation in the evening as needed for phase advance. This patient reports few symptoms, no fatigue during the day. The cortisol levels look good, but they did have difficulty falling and staying asleep. We tested their melatonin, just a single point melatonin right before bed. We could see that it's low. So this person could benefit from some melatonin supplementation. This is melatonin level in a shift worker on a non-work day. So note that the curve is upside down because on a work day, this person would be asleep. So this is a good reminder that for shift workers, we want to see what their melatonin levels look like on a typical work day. If they have a 10 to 6 shift, the morning collection should take place about half an hour after they wake up. So let's say this person wakes up at 8 o'clock p.m. to get ready for their 10 o'clock shift. So they would collect their first sample at 8:30. Then they would collect before whatever their lunch is, usually 4 hours after starting work. So they would collect before 1 to 2 a.m. before they eat their lunch. And then they collect again before dinner, which might be at 6 a.m. And then right before they go to bed. So in a non-shift worker, an elevation like this could be due to too much phytomelatonin exposure the day of testing, because it wasn't so high in the morning, but maybe they were consuming a lot of foods rich in phytomelatonin that day, which could skew the results. 20% of the population in industrialized countries works in a job with non-standard shift hours. 10 to 38% of these workers suffer from shift work disorder, which is marked by excessive sleepiness when awake or inability to sleep when needed, which makes so much sense. So here are some considerations for those patients, just as with everybody else, but they're going to be on a slightly different schedule. So when they wake up, expose them to some full spectrum light within 1 to 2 hours, regardless of whether it's a work day or a shift day, just to set that rhythm. 10 minutes of light every couple of hours to help mimic that natural daylight. If they can have a full spectrum light box with them somehow at work, I mean, obviously not everybody's going to be able to do that, but if somebody does have that, and even if they can't be exposed to a light box, if they can be just exposed to any artificial bright light every couple of hours to mimic that daytime phase. They can dose melatonin anywhere from 2 to 7 hours before bedtime. Again, the research is very, very different on this. I think with a shift worker, it's best to dose 2 to 3 hours before they want to be asleep so they can start that winding down process. They can wear dark sunglasses. They can wear dark sunglasses when they get off work, even if it's still dark out, so that they can minimize either the effect from the lights when they're driving home in their car, or in the morning, if they get off in the morning when the sunlight's starting to rise, the sunglasses is going to help to dim that light and be less stimulating to the suprachiasmatic nucleus. Important that they wear a sleeping mask or they have room darkening shades when they're going to sleep. They can catch up on sleep on their days off because we know about the long-term effects of sleep deprivation. So this is really important to remind them it's okay to catch up on sleep. Taking naps is a great idea. Being careful with caffeine, not using it past approximately not using it past 6 hours before they're going to be going to bed. Regular exercise, and of course that sleep hygiene that we talked about. So jet lag, a great little support for jet lag is when somebody gets to their destination, they can take anywhere from 0.5 to 5 milligrams. Higher dosages have resulted in shorter sleep latency than lower dosages. So this might be a place where you would give somebody a higher dosage of melatonin to avoid jet lag at their destination. So let's talk about the role that melatonin plays in modulating the immune system and its potential role as COVID treatment. And I apologize because I might have to do some reading in this section because it's pretty technical. Melatonin doesn't have direct virucidal properties, but it does have indirect anti-inflammatory and antioxidant and immune enhancing actions. T lymphocytes, killer cells, and mast cells all contain melatonin receptors, and melatonin supplementation has been shown to increase the proliferative response of rat lymphocytes and killer cells. So in this way, melatonin serves an immune activating role. It also has an immune dampening role by inhibiting NF-kappa beta and blunting the production of pro-inflammatory cytokines. So in this way, it's wonderfully modulatory on the immune system. In human studies, melatonin has been shown to have antioxidant and anti-inflammatory effects in the lungs of newborns with RSV. 5 to 20 milligrams have been shown to reduce IL-6, TNF-alpha, and CRP, all inflammatory cytokines. Also, this has been shown in diabetes and in periodontitis. In an MS trial, supplementation with 25 milligrams a day for 6 months promoted the reduction of cytokines and markers of oxidative stress. So super powerful. And we talked about a little bit already about melatonin in the lungs. These are some of the references for the previous slides. So a quick review on inflammasomes. They are the large protein complexes that initiate apoptosis and pro-inflammatory cytokines in the lungs. We were hearing a lot about this during the vaping crisis before the COVID pandemic. And then of course, we were hearing a lot about this at the beginning of the COVID pandemic, because this is what was causing that fluid in the lungs, all that inflammation, and that pneumonia type process that people were having. So leading to those inflammasomes lead to a cytokine storm or an excessive immune response that damages lung tissue and causes respiratory failure ultimately. This image is associated with the previous slide, and it shows you the inflammatory cascade that produces NF-kappa beta and NLRP inflammasomes, and all the places where melatonin can have a protective and modulatory effect and dampen this process. This is a review paper that was just published in February of 2022. Melatonin highlighting its use as a potential treatment for SARS-CoV-2 infection. They surveyed over 140 studies, retrospective case studies, randomized double-blind, randomized perspective. They used 3 to 10 milligram dosages and found that all of these factors contributed to an improvement in cytokine storm and multiple organ failure that's seen in COVID-19. Here are some more of those outcomes. Increased survival, blood O2, sleep time and intubation on melatonin, and decreased need for ventilation, duration of hospitalization, pulmonary symptoms, CRP, sepsis, microvascular coagulation, and then also just a decrease in mortality and COVID symptoms in general, as well as a decrease in the need for intubation. So while we've talked a lot about melatonin, we haven't spent much time on sleep. I wanted to address the inflammatory nature of insufficient sleep and how it can contribute to the conditions that set one up for the most adverse effects of COVID-19. So here you see a cell where melatonin can pass through the membrane and bind to protein receptors on the nucleus surface. So it can penetrate the nucleus and act on chromatin with a direct effect on protein synthesis. But this image specifically is showing you melatonin's impact on mitochondrial cells, where melatonin is found at a greater concentration even than it's found in blood. So these high levels serve as a potent antioxidant to protect the organelles from free radical damage as it occurs during aging and as a result of diseases that have a free radical component. So remember that the mitochondria are the major source of intracellular free radical production because they're byproducts of normal cellular metabolism. They do cause oxidative damage, and so that melatonin is so important to counterbalance that, and it helps to keep the membrane fluid so that the things that we want to get into the cell can get in, and the refuse can leave the cell with that nice permeable membrane. In order for melatonin to serve its potent antioxidant and anti-inflammatory properties, high concentrations are required in the tissues. Disruption of these processes, or the natural production of melatonin, leads to mitochondrial dysfunction and the development of diseases such as cancer, inflammation, fibrosis, Alzheimer's, MS, etc. So this realization, which took place in the scientific community right at the advent of the 21st century, has led to a new biomedical discipline that they call neuroimmunoendocrinology. And there's plenty of clinical studies that suggest that timely diagnosis of these violations of pineal gland and extrapineal gland production of melatonin can act as a really important marker of disease. This is a fascinating and very long review article entitled "The Sleep Immune Crosstalk in Health and Disease." I urge you to take a look at it if you find this topic interesting. The authors concluded that in the absence of an infectious challenge, sleep appears to promote inflammatory homeostasis through its effects on inflammatory mediators like cytokines. So this image shows you the inner white area where with a natural response to microbes, and how sleep can actually modulate the immune system. This left area, left and right area here, shows you the pathology around how immunity impacts sleep. Too much of an immune activation response will disturb sleep. On the right, this outer pink area shows how disturbed sleep for too long will lead to insufficient immunity and ultimately disease states. Because it mimics infection, vaccination is an optimal experimental model to tackle the question, how does sleep impact an acute immune response? So this research showed a reduced antibody response when receiving a vaccine after a night without sleep. Those who were allowed to keep a 7 to 8 hour normal sleep cycle had double the titers of those whose sleep was restricted to 4 hours. And they ended up having to revaccinate some of the people who had the low sleep before they got their vaccination because the titers were so low and they were not protective. We've been talking about the medications that disturb sleep. I found this research from March 2020 chilling and important to keep in mind because of the impact that the pandemic has had, not only on immunity, obviously, this immune challenge of the pandemic, but also how it's impacted mental health. This graph reflects research from Express Scripts, which is an online pharmacy, and it shows that anti-insomnia in green, antidepressant light blue, and anti-anxiety prescriptions increased in total by 21% between February 16th and March 15th of 2020. So keep in mind that on March 11th, the World Health Organization declared a pandemic. Anti-anxiety medications alone in the dark blue rose 34%. 78% of all anti-insomnia, antidepressant, and anti-anxiety prescriptions filled during the week that ended March 15th were for brand new prescriptions in people who had not used these medications before. Fortunately, melatonin has been extensively reviewed for its impact on mental health, with doses ranging from 3 to 10 milligrams. It's been shown to be equally and more effective than benzodiazepines in reducing anxiety before and after surgery. It's also been shown to work better than benzodiazepines for sleep, anxiety, and depression. So in somebody who's really struggling, you might give them some melatonin during the day to avoid a pharmaceutical. So I'm going to skip this because I want to get to questions. Here are some take-home points that you can look at summarizing what we just talked about. And I'm going to leave you with this reminder of melatonin's profound effects on the human body, and to remind you of the role that it can play in your clinical practice. And I'm happy to take some questions now.